So by shortening her abdominal muscles, her shoulder moved better. So this is something we teach the ins and outs of in our Primal University courses, especially our Primal Foundations course. And you would get a lot of in our mentorship program. But learning how to, to get patients to that extra percent better, that extra top 1% is to treat the whole body as a system and to look for these relationships.
Welcome to the Dr. J.J. Thomas Podcast.
Hey everybody, welcome to the Dr. J.J. Thomas Podcast. I'm J.J. Thomas. I have Shanon here today with me. Today we're going to dive into shoulder impingement and how to better evaluate your patients with shoulder impingement in a way that gets you to sort of the diagnostic approach of where to treat first faster. So I'm going to show you some of the little tips and secrets that I've seen along the way with evaluating motion just a little bit more deliberately in certain phases that can help hopefully direct your clinical patterning so over time you know where to go faster and you can make the most out of your time and their time and just, like I said, get them better faster. So here we are. So Shanon is one of our staff here at Primal PT. We call her Disney Underground. She and David keep us running on a lot of levels. But she's here today. We're going to go through some motion patterns, and actually, I'm going to have you stand up first. Still in frame? Good. And just stand facing this way, actually. And let's actually square you off this way. Good. I'm going to pull your hair behind your head, like that. Okay. So the first thing I want to teach you guys is when testing shoulder patterns, so a lot of times what I'll do is a gross motor pattern first, and I want you to get in the habit of looking at where the pattern seems to be limited during each phase of the motion. And this is what I mean by this. So Shanon, I'm going to have you just take that right arm and go straight up into flexion as far as you can, and good, and come back down. And almost everybody wants to please us, every patient, every athlete, every coworker. So a lot of times they'll bend their elbows. So we have to, if we're going to really tease out the motion, you have to make them be really deliberate with keeping that elbow straight. So let's do it again, Shan. Keep that elbow really straight and go back there. That's good. Now go back as far as you can with your arm straight. See how that's restricted for her. I'm going to come on this side so I can show you. And let me just tuck that in. At that end range, I'm starting to look at already. Come back down. Let's do it one more time. Let's go ahead and take that off. She has a bruise. She got a little bruise from some treatment earlier, just a few days ago. But so elbow straight, go straight up as far as you can. Awesome. Try to push it back as far as you can. So you can see she has to work. That's efforted, right? So that is not a clean, pure motion. I'm already looking at where does that seem like it's tying up. If you look, you can see these fibers here sort of straining at that, this front pec. And Jess treated her here. Jess did a good job. I think Jess saw what I'm seeing here because she clearly left a bruise in a spot that I would have treated. So yeah, that's limited there. And a lot of times we're looking at what's happening at the shoulder blade. A lot of times, Shanon isn't so bad here, but you can go ahead and put it down. Am I still in the frame here? A lot of times what you'll see is that shoulder blade, when they come back, will like pop out a lot. And then I'm going to evaluate, I'm going to look more closely at this like lat, teres major, teres minor area when that's limited. Now the other piece of this that we're going to look at, go ahead up into that end range again with your elbow straight, and then go straight up, back as far as you can. From here, I want you to take this hand and touch over to the opposite shoulder, so over here. Good. Now, for Shanon, that didn't change. For some people, when they go to do this and they go to touch behind, their arm comes forward. They struggle with that. You can put it down. What that tells me is that their tricep is involved, right? Because if you're here and then all of a sudden you can't maintain that shoulder flexion as you go to just bend the elbow, then the only thing that is changed when we're bending the elbow there is the tricep, and that long head of the tricep attachment attaches into the scapula. So when they do this, if it's more efforted, then I know that long head of the tricep is affecting their shoulder. So that's a little secret there I wanted to share with you. Let's look at the flexion internal rotation pattern. Extension internal rotation pattern. So now you're going to go back like this, Shanon. Elbow straight, go back as far as you can, keep your chest up. And I'm going to come on the other side. And that looks pretty good for her. So come on back down. A lot of people, when you're looking at that, what you'll see is, even if I say, bring your elbow straight, bring your arm straight back as far as you can, they'll dip like this. And then I'm going right back to that pec region again. For Shanon, it wasn't too bad. So now I'm combining my findings. When she went up, it looked tight in that pec region, but more in that like anterior delt pec region. When she went back, her pec didn't pull her forward. So I'm definitely thinking more anterior delt here for her. So just paying attention to what's happening at the rest of their body when you're giving them the cues and ask them to do that extension pattern. So now Shanon, go straight back into extension. Her pec does a nice job of staying erect there. From there, can you touch behind to the opposite shoulder blade? And now that's where she comes forward more. So let's come out of it, turn that way just a little. Good, go straight back again, and then from there, touch behind. So you see how when she goes to internally rotate, she gets a lot of forward pull there. So now that brings my brain more, come on out of it, to this posterior cuff. So infraspinatus, maybe supraspinatus, but definitely infraspinatus and teres minor, teres major, sometimes teres minor and lats as well. You have to tease that out prone, which is what we're gonna do in a minute. But the other thing I wanna teach you guys real quick is a regional interdependence thing that you should check, and that's, go ahead and have a seat on the table, Shan. And that's checking shoulder flexion, shoulder patterns, specifically shoulder flexion and external rotation in sitting versus standing. And so Shanon, from that position, go up as far as you can. That's easier, isn't it? So she actually has better range there. So what does that tell us? What did we change? The only thing we changed here was her hip and abdominal position, right? So that actually tells me that her potentially tight hip flexors and abdominal tightness are affecting her shoulder. So these muscles are pulling all the way on her ribs up to the pecs and manifesting as tightness in the shoulder. So let's just highlight that again. So stand up, and then, yeah, that's good. From there, raise straight up overhead, elbow straight. You can see it pulling at that end range, right? Let's give them a side view of that, so face that way. So elbow straight, go straight up, back as far as you can. Right there, you see how right there it's like zoom, the whole shoulder blade goes, and you can see she just can't get there as far. Let's sit this way, Shan, so they can see better. And then do the same thing in this position, elbow straight, go straight up. Easier. See how she goes? Her range is further and she gets there better. So by shortening her abdominal muscles, her shoulder move better. So this is something we teach the ins and outs of in our Primal University courses, especially our Primal Foundations course. And you would get a lot of in our mentorship program. But learning how to, to get patients to that extra percent better, that extra top 1%, is to treat the whole body as a system and to look for these relationships. Now, in some people, their shoulder flexion range might be worse when they're sitting. And what would that tell you? It would tell you that her low back tightness, or specifically her posterior chain, in some way, shape, or form, could be your glutes, are limiting her ability because we're putting stretch on the posterior chain. So if her shoulder flexion gets less there, then I know that I'm gonna loosen probably her low back and posterior chain, but I would tease it out specifically. And that's what we teach you how to do in detail in our courses. Let's do one more piece of this evaluation. So now, Shanon, I'm gonna put that back up. You're gonna go face down. Yep, thank you. Good. And then, this is something I originally learned through SFMA, and I'm not honestly sure at this point if I learned the sort of looking at every component through them or not, but I'm gonna show you it anyway because it's very, very valuable. So elbow straight here and lift straight up. And so she still wants to bend that elbow because she wants to, there she goes. And I know that I can bring her further than she can bring herself. So that's a motor control deficit. But again, my point to you is we wanna look at where we see her limitations. So do it again, Shan. Yep, lift up. And then when I bring her up, all I see is the scap in this position is really riding out this way. And so when I go to treat her, I'm gonna definitely work a lot in this infraspinatus, in this, the triangular interval is made up of teres major and the two heads of the tricep, the long head and the lateral head. And so all of those and teres minor in here are a real great spot for these people with shoulder impingement. And when you loosen all this stuff up, then their end range flexion gets better. And all their motion gets better, external, internal, all the motion. The other thing that you can look at is if they have a motor control deficit, go ahead up again, Shan. Look at, again, how they're pulling here. So lats are often a factor, and low trap. So low trap will also be a big player. And if I feel Shannon's, I can see that it's really tight there. So that's something I would normally needle on someone like Shanon. But for Shanon specifically, go ahead and sit up. I actually didn't expect to be teaching you guys this, but it's so much fun when we do these live scenarios. So for Shanon, I would definitely, number one, massage and or needle her abdominals. I would evaluate her anterior chain, meaning her hip flexors, because when we shortened them, her shoulder flexion got better, including the adductors, because the adductors are hip flexors as well, most of them. And then I would go to I would retest right after that so that I could see how that changed her shoulder immediately. I already know it's going to change her shoulder because her shoulder range of motion and flexion is better in sitting than standing. And then I would tease out the shoulder further. And I would probably end up addressing, if it was still present, the anterior delt tightness that we picked up on shoulder flexion and the posterior cuff tightness in the infraspinatus, teres minor major, and long head. Actually, for her, triceps wasn't involved because when she bent her elbow, it was the same. So that's how I would treat her in terms of interventions. I also want to go through some exercises with you guys right now. My 5 favorite exercises to give to our patients with impingement issues in the shoulder. Remember that ideally you're going to give them exercises that are very specific to their deficit, right? So for Shanon, we're going to make sure that we're also addressing her anterior chain deficits in her abdominals and her hip flexors. And you can combine that with exercises. We'll go through it in a little bit. Hey guys, welcome to the mat. I'm going to go through some of my 5 of my favorite exercises to give our patients with shoulder impingement. And I love them just because they're very integrative. As we talked about, treating the body as a system, if you're really going to treat and train the body as a system, you need to incorporate the shoulder exercises you're doing with your patients, we need to do that, in other positions that will also incorporate the rest of the kinetic chain. So Shanon, thank you for being here. I'm going to show one of my first favorites, very basic. I'm sure you guys already give this one, but I want to point out a couple details with them. Shanon, you're going to start in like a high plank position. Let's do a side view, actually. Great. So, yep, Shannon's doing a great job because she's here and knows how our standards for things. Shoulders are stacked over wrist. Head is in neutral, so not letting the head hang, but the ears in line with the shoulders. Belly lifted, tail tucked. That's perfect. Now, I'm locking the lumbar spine here, and now I'm going to ask Shanon to let your shoulder blades fall together without letting this fall. Great. And then push the floor away farther than you think you can. Get that thoracic round. Now, this is really a serratus punch, right? A closed chain serratus punch. And we're also, on the way down, go ahead, down again, getting scapulothoracic mobility, which she needs, which is going to stretch that rotator cuff on the outside as she comes down. Come on, back up. Now, Shanon, on this one, let your back sag, which I would normally not let you do. So come down. Yeah. So that's not going to get the scapulothoracic mobility we need. It's going to have people sort of just compensate through their low back again. We're almost done, Shanon. To keep this nice and high, tuck the tail. Great. Let's do one more rep. Let it sag in. Only the shoulder blades, then drive away further than you think you can. Get that round here. Push, 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 push. Yes, and that's it. So take a break. That was great. So those are the cues. Yeah, intention is everything, right? Those small details mean everything. So making sure that the lumbar spine is locked, making sure that the tail is tucked, making sure Shanon also automatically did fingers spread and elbows straight, which all of our patients will not do immediately, but that's another thing, because if they're in this position, I'm just going to go next to you, and they're doing this, meaning elbows are bent, they're using their bis and tris more than they're using cuff, exactly. So when they come down here, they're going to get that cuff stretch if they're holding all those things with intention. So now, that's my first favorite exercise. And that's basic. Almost everyone gets that day one, because if they don't have that scapulothoracic control, their cuff is going to compensate again and again and again and again. My second favorite exercise for them, and these aren't necessarily in order, but these are my first top 2, is the oblique plank reach throughs. So Shanon, I'm going to have you, we'll go this way now so they can see. So plank in this position. Same standards, fingers spread, elbows straight, shoulders stacked over wrist. This time I'm going to have you take one arm and reach through the other one. Yep, good, come out of it. Let's widen your feet a little bit more so that you have a little bit more even. Yeah, and then reach through again. So as she's reaching with her left, come back down, and other side. As she's reaching with her left, touch the ground the whole time. And then come back. As she's reaching with her left, her right cuff is controlling that eccentrically. Reach with the left, keep the arm in contact the whole time, and you can see how that's harder for her. That side, reach with the right, reach, 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 excellent. Reach with the left, go slow, only go as far as you can go, controlled. Yeah, she has a hard time controlling her hips on that one. Now, come on out of it. The reason this is a great exercise for everyone is that, as I said, eccentrically, as they reach, so for Shanon, it's her right cuff. As she reaches here, her cuff is controlling that relative horizontal adduction. She's getting eccentric cuff activation of those external rotators. It's beautiful. Plus, she's getting abdominal activation at the same time and learning to control her hips under her pelvis and under her spine at the same time. So it's a great, great exercise for a billion reasons. The next one you're gonna do is another one of my favorites. We're gonna do backwards bear. I'm gonna teach her forward bear first, and then she knows it because she works here. But and then we're going to do backwards bear, because backwards bear is really the most important one for these cuff patients, these impingement syndrome patients, and I'll tell you why. So Shan, come on sideways again, head facing that way. Good, and fingers spread, elbows straight, tuck your toes, and come up into that A-frame. This is a GMB Fitness special. Good. Now, in this position, Shannon looks great. Holy crap, that looks so good. Let's walk your hands away a little further. A little bit, like keep them a little further, and that's just for you guys listening. I'm doing that because I want the weight on her shoulders. I want scapular stability, I want shoulder stability. Walk a little further even. Good, now relax the heels. Awesome, that's a great start position. Now Shannon, opposite arm and leg slide together. I want you to move opposite arm and leg just a few inches. Great, and then the other one, just a few inches. And then the other one, just a few inches. And then the other one. Good, now go backwards. Drive with the base arm. That's it. Opposite arm and leg still slides together. Perfect. So imagine she's getting a single arm press here through this backwards bear. Come on out of it. It's hard, way harder than it looks. Shannon made it look easy. So a couple cues there, a couple tips to remember. Most patients are used to the yoga concepts of and we're ingrained that we need flexibility, and a lot of patients will immediately go into like a downward dog where they're like here and they're trying to get their heels flat. See how here, first of all, my head peeks out from my shoulders there, and there's less weight on my hands than my feet here. I want the weight on my hands because I want that shoulder stability. So even though Shannon's A-frame looked amazing, I had her walk her arms away so that she would get more weight on her arms than her feet. And then forward, opposite arm and leg slides together. Most people will accidentally bend, and then all of a sudden we're missing that frame. We're missing that shoulder frame to get scapular stability. And then backwards, this is where, so if you go opposite arm and leg slides together, see how this trail arm drives away, boom. And it's in relative overhead position. So most people in that impingement process are getting impinged because their scapular control at shoulder flexion ranges is poor. So all of a sudden now you put them in their end range shoulder flexion and you ask them to drive the floor away, engaging serratus anterior and all the other scapular stabilizers, and they have a win. Not only that, but now their core is engaged at the same time, so we're treating and training the body as a system. Now for Shannon specifically, I want to add a variation because of her hip flexor tightness. So come back into that position for me, and I would give her backwards bear because it's amazing, but I would also say come forward just a little bit so you're in the frame. Great. So right there, I would have her in that position. Now I would have you, so it's her right shoulder, so I'm gonna have you raise opposite leg. Yep, and raise it high, like super high. Good. And then from there, I want you to press the floor away. Like, that's it, and then come back. Good, so press away. So we're basically getting scapular protraction in shoulder elevation while she's maintaining this leg in a hip extended position. So now I'm integrating those hip flexors that were limiting her in standing over there. Pretty cool, right? Come on out of it. So that was just something I created on the fly for Shannon because when we evaluated her, her hip flexors and abdominals were clearly limiting her shoulder flexion capacity. So we can put her weight bearing, engage the shoulder flexion, the stabilizers we need in shoulder flexion, and then integrate that hip to get it extended when the body feels safe because it's in that loaded position. So thank you. Mm-hmm. 2 more quick exercises. This one's gonna involve dumbbells. So basically, you can stand, Shan. You can have them do the stand, actually we'll do it standing. Okay. So you're gonna stand in front of the camera and I'll stand next to you, stand facing that way. Yeah, and then you're just gonna start with your arms at 90-90. Good, we good here, Dane? And then you're gonna fly out your arms like this. When she does this, I wanna make sure that this isn't already falling, so she did a nice job of keeping it in line with her elbows, and then I want you to rotate it up. Now, soft bend in the knees, I want you to hold that rotation as you bow forward like a good morning. Eyes forward, eyes forward. Yes, a little bit more, look at the camera actually.
Makes it hard.
and then come up, yes. Well, it makes it, but it also engages your spinal erectors. So by having her make sure she's looking forward rather than down, yeah, you can take a break. She's engaging her spinal erectors, which we know she needs also for scapular engagement. So one more time. So fly it up, rotate it up, soft bend in the knees, eyes stay forward, and good morning, down. Awesome. And then come back up in that position. And then reverse it all. So now fly, yep, and fly, and then down. So what she's doing is she's doing an active rotator cuff exercise with the dumbbells, but then she's maintaining it as she's integrating a bow into a good morning exercise and teaching her shoulders to stabilize as gravity changes the demands on her spinal erectors and the rest of her body as it relates to her hips. So another good one. Yay, fun, right? And then the last one, we can put the weights away. The last one is I ended with this one because it's truly a stretch. Like this next exercise is a traditional stretch. Any of you that follow me regularly know that, I do give stretches, but for the most part, I also believe that most mobility issues will improve if you give the body the stability that it needs. And so this stretch, sometimes you do need to do stretches to be able to perform the stability exercises, but not always. Sometimes if you just do those first 4, then the mobility itself will improve. But let's show it anyway. So Shanon, for this one, you're gonna lie on your right side, so it's her right shoulder, face the camera. Yep, I'm gonna grab a pillow, yep, for your head. And then, right, you're gonna have, so actually, this arm, I'm actually gonna have you, so 90 degrees, can you see us? 90 degrees, I want you to pull this shoulder blade back as far as you can get it. Pull it, pull it, pull it, pull it. Yes, a little bit more, yes. So I actually pulled her shoulder blade back, and then bend your elbow. She's really at close to 90 degrees. She came down a little bit, so bring that elbow up a little bit towards your face, yep. And then keep this here, take this hand, put it under the elbow, and then lift this up towards the ceiling. That's great. Feel that stretch in the back of your shoulder here. And then I usually relax your head, but keep this up. I don't have patients count, I have them breathe. So 5 long, deep breaths here, and that's then I know she's getting rib expansion to get the most out of the exercise, and it's a way of counting without being like 1, 2, 3, 4, 5. So it's 5 long, deep breaths, and that's the exercise. The things that will go wrong there, as you guys probably use this one, the therapists that are watching, I'm sure, use this one. Some of you use the sleeper. The thing I don't love about the sleeper is most people end up pulling their shoulder blade out, and then you're not getting that corner that gets so tight here. But when you do this one right, you lock them back, and then you pull, then you're getting that component here that's so tight in the cuff. So this is my go-to over the sleeper stretch. If you're not using it already, give it a try. See if you like it better or the same as the sleeper stretch. I'd love to hear from you. Those are them. Those are the 5. These are the exercises that I consistently give to my patients with shoulder impingement syndrome, pain at night, limitation in those end ranges of either flexion patterns or extension patterns. So that's it. I hope you learned something. I hope you enjoyed it. Thank you so much, Shanon, for donating your time and body. And let me know if you guys have any questions. Love hearing from you.